Let's spend a few minutes talking about variant histologies that are oftentimes encountered. I feel like this is something that can be confusing, and maybe we'll just kind of run through the gamut and get a quick neoadjuvant chemotherapy, yes or no. How about a pure squamous?
Ah, you're tying my hands. Can I say it depends, or is this a move on? Yes or no?
No, no, absolutely no. I'd love to hear your kind of thought process here.
Okay,
100%.
sorry to make it complicated, but I think squamous is difficult because if I have a small tumor and it's pure squamous, I may skip the neoadjuvant chemotherapy and go straight to surgery and consider adjuvant radiation therapy. If I have a very bulky tumor, then I do try to use neoadjuvant chemotherapy to refer to, and these are, I think, case by case basis discussion at tumor boards and seeing what we can do. But cisplatin is effective in some squames, but not all. So I think it depends. I think the Egyptians have some data on other regimens being effective as well. But those are perhaps different than the squamous cells that we see in the US. So I'll go with a maybe on that one. Is that okay?
No, totally. I wholeheartedly agree. I mean, you can read the Egyptian literature, and it seems like it behaves a little bit more indolently, a bit of a different disease state than the pure squams, which are admittedly very uncommon here. But it resonates. And then for the sake of completeness, if it's urothelial NOS with squamous differentiation, is that going to be a chemo candidate typically in your hands?
I'm sorry, if it's what?
If it's primarily urothelial NOS garden variety with squamous differentiation.
Absolutely, that's a yes.
Okay, fantastic. What about adnos?
That's a no on that.
Yeah, whether urachal or non-urachal, straight out with surgery, get the histology and take
Exactly.
it from there. Do you
Yeah.
do endoscopies, upper, lower, and so forth in patients with adnos to rule out any other primary?
Now, certainly, I think if it's very obvious, you have a negative CT scan, you can probably move forward. I think, the classic teaching and the textbook teaching is, yeah, look for a colon primary. But honestly, if you're going to have a colon primary, there's got to be big enough to metastasize directly right to the urachus. That's going to be fairly rare. So if it's fairly obvious, then we move forward. I think the difficult ones are the ones where it's locally advanced and it's going from the dome of the bladder directly into the sigmoid next to it, and you really don't know whether it originated from the sigmoid or the urachus. They both can be mucinous adenocarcinomas. Those are the slightly difficult ones for me. But I think at the end of the day, the treatment is pretty much the same, right? We would do a partial cystectomy with a sigmoid resection on block, and I don't think it really changes where the tissue of origin was.